Okay, next topic is the AA gradient. Thought I was going to freeze there. Okay, so big A, small a gradient. Remember, alveolar arterial gradient. Okay, this is a little bit more simple than some of the other lung equations. It's basically the partial pressure in the alveoli minus the partial pressure in the arterial. This is oxygen, right? P big A O2 minus P small a O2. And remember, the P big AO2 is determined by the PiO2, which is the pressure of inspired oxygen. And that's determined by the fractional percentage of oxygen, which is 21% in the atmosphere, times the normal atmospheric pressure minus pressure of water vapor. And so normally that's like 760 minus, was it like 713 or something like that. But, at high altitude, we're decreasing this. And I'll talk about that next time, but just another reminder of that. Normal is 5 to 15, so that is a good range to memorize. You will also see 0 to 10. It's rarely 0, because that means you would have like perfect, that means it would be like perfect transfer, and it's never really perfect in real life. And as we saw in the last lecture, often used to compare causative hypoxemia or low P small AO2. And I'm just repeating this from the last time. This is in the context of the AA gradient. So hypoxemia, if you see decreased PaO2, which is the definition for hypoxemia, but there's a normal AA gradient, it can only be two things that you should think of. Some cause of hypoventilation, and these are kind of external causes, okay? Like drug overdose, benzos, opiates, anything like that, and high altitude. Okay, and the reason for the normal gradient is, so remember, it's P big AO2 minus P small a O2. This is the most intuitive reason. I think this is correct. I hope it is. But these situations decreased the P alveolar O2. Right? If you're breathing less, it means less oxygen are getting to the alveoli. If you're at high altitude, it means less oxygen is reaching the alveoli. But if there's a corresponding and equal decrease in the P small AO2, then the gradient will still appear to be in the normal range of 5 to 15. Does that make sense? Okay, now if you see the same situation but an increased AA gradient, you're going to think intrinsic causes or internal causes. So intrinsic pathologies of the lung. And remember, with these situations, gas exchange at the the level of the alveolus and the pulmonary capillary is okay, right? That's not where the problem is. Whereas in these situations, gas exchange is not okay, and that's why you see an increased AA gradient. That means just some kind of ventilation perfusion defect, a mismatch, right to left shunt, where blood from the right side of the heart is going to the lung, without getting oxygenated. Or diffusion impairments like interstitial fibrosis between the alveolar wall and the capillary wall would be an example. So anything that is going to decrease the P small aO2 and increase the AA gradient will be like intrinsic causes of that's going to impair gas exchange. Now we talked about the importance of this, right? Think two things. It's going to be a test question. Now, this is another important kind of clinical question. If you give supplemental oxygen to any of these first four patient scenarios, diffusion defects, ventilation perfusion defect, they will usually improve. Okay, the symptoms will usually improve. But if there's a right to left shunt, it does not improve. And this makes complete sense, right? Because right to left shunt means there's some problem. Let's see, alveoli. So PaO2, let's say, equals PaO2 of 40, and then when it leaves, let's say it's the exact same. So that means it's not getting oxygenated. So no matter how much oxygen you give the patient, there will be no improvement of the symptoms or the AA gradient. So the AA gradient will not normalize if you give supplemental oxygen in the case of a shunting pathology. Okay. And now, quick word on diffusion limited and perfusion limited gas exchange. I always hated this concept, but I'll do my best to boil it down. If you want to memorize this, it can get you by. Which gases are perfusion limited and which gases are diffusion limited. High yield. I don't know if I'll do well explaining why this concept's important, but I'll do my best. These three gases, CO2, N2O, and O2, under normal conditions are perfusion limited, and then carbon monoxide and oxygen during exercise are diffusion limited. I don't know, during diffusion, I don't know, whatever helps you remember. Okay, so let's start with perfusion limited right here. So CO2 and O2, the way I like to think about it is we want O2 to be very good at following its concentration gradient entering the blood, and we want CO2 to be very good at following its concentration gradient and entering the lungs. So those gases, as you can imagine, are going to follow their concentration gradients very effectively and reach equilibration quickly. Okay, so this, as you move along the length of the pulmonary capillary, this equilibration is reached very quickly. And the equilibration between P small a and P big A. And so what that means is that when they say perfusion limited, that means the only way to increase the efficiency of this gas transfer right here is to increase the blood flow. So increase blood flow, aka increase perfusion, means increase efficiency. Hopefully I'm explaining this in a way that makes sense. Now, diffusion limited means that equilibration, so basically just flip your thinking, the opposite is true. So equilibrium is not achieved. See this like difference here. So what that means is as long as the gradient is maintained, the diffusion will occur. And okay, remember this is perfusion, and then diffusion of gas is its ability to move across. Diffuse follows concentration gradient and move across cell membranes. And usually it's in the case of, well, yeah, think of it in this case of going, in the case of carbon monoxide and oxygen during exercise, we're thinking of diffusing from the alveolus into the capillary. Okay? Gosh, stop doing that. How do I want to highlight this? Okay, so let's take carbon monoxide for example. As long as the gradient is maintained for carbon monoxide to go from the lungs into the bloodstream, it will continue doing that pretty much forever, theoretically, as long as the gradient is maintained. And so why that is a bad thing is, like, once carbon monoxide gets in the blood, remember it binds hemoglobin. And then it will, move on. And then there's more hemoglobin molecules that come. And if, as long as carbon monoxide is still inhaled, like you're smoking cigarettes all the time or something like that, then more carbon monoxide can go into the bloodstream and bind hemoglobin, and that process can repeat itself as long as the pressure gradient is maintained. So diffusion limited, perfusion limited. Okay, summary of the AA gradient. So the AA gradient relies on continued perfusion of the capillary to remove the gas that enters, and that makes sense, right? Increased gradient signifies the lack of oxygen equilibration between alveolar gas and systemic arterial blood. And in that concept, remember that's this in graph form, equilibration. Okay, so in times of pathology, if you see hypoxemia, so if you see decrease PaO2, but a normal AA gradient, it's extrapulmonary origin, so like external causes. And quick quiz, write down the two things you're thinking for causes. Should know it by now, hopefully. But if you see the same thing but an increase AA gradient, that means the decrease in PaO2 is of pulmonary origin, intrinsic causes. So write down the three things that cause that. Medically significant AA gradient, usually around equal to 30 or above. Okay, we will do this for the next one.